Care of clients with special needs by Jones HMMBADMS. Pain. Outline. The concept of pain. Physiology of pain. Types and causes of pain. Assessment and management of a client with pain. Introduction. Pain is a complex, multidimensional experience. For some, it is a minor inconvenience. For others, it is a major problem that causes suffering and reduces quality of life. Pain is one of the most impelling symptoms that prompt a person to seek medical advice. It provides a protective role as individuals learn from early childhood to avoid and correct situations which cause pain. It should, however, be remembered that there are serious diseases such as heart disease, which may be painless at the onset. As a result, a person may delay seeking medical advice until the disease is in advanced stage. Pain management occurs in all clinical settings and among many different groups of patients. Nurses have a central role in pain assessment and management. Knowledge about the concepts related to pain, data collection and useful therapies is essential in the management of pain. Unnecessary pain can result from incomplete pain assessment or treatment based on assumptions rather than on patient data. Concepts associated with pain. Pain threshold: the least experience of pain which a subject can recognize, or the lowest limit of perceiving the sensation of pain. Pain tolerance level: the greatest level of pain which a subject is prepared to tolerate. Nociceptor: a high threshold receptor which responds to stimuli such as burning, crushing, cutting, or pressure sufficiently intense to cause tissue damage. Nociceptive pain: pain that arises from the stimulation of specific pain receptors. These receptors can respond to heat, cold, vibration, stretch and chemical stimuli releases from damaged cells. Non-nociceptive pain: pain that arises from within the central and peripheral nervous system. Specific receptors do not exist, with pain being generated by nerve cell dysfunction. Definition. Pain is whatever the experiencing person says it is existing, whenever the person says it does. Lewis et al., 2004. It is a personal experience that is influenced by genetic, psychosocial, and cultural factors. Or pain is a complex, distressing experience involving sensory, emotional and cognitive components. Watson and Royal, 1987. Or a bodily sensation that is induced by a noxious stimulus, is received by naked nerve endings, and is characterized by physical discomfort and typically leads to evasive action. Physiology of pain. A subject begins to feel pain when nociceptors in the skin, muscles or internal organs detect pressure, inflammation, a toxic substance, or another harmful stimulus. The pain message travels along peripheral nerve fibers in the form of electrical impulses until it reaches the spinal cord. At this point, the pain message is filtered by specialized nerve cells that act as gatekeepers. Depending on the cause and severity of the pain, the nerve cells in the spinal cord may either activate motor nerves, which govern the ability to move away from the painful stimulus, block out the painful message, or releases chemicals that increase or lower the strength of the original pain message on its way to the brain. After the pain message reaches the brain, it is relayed to the thalamus, which transmits the information to three specialized areas within the brain. The somatosensory cortex, which interprets physical sensations. The limbic system, which forms a border around the brain stem and governs emotional responses to physical stimuli. And the frontal cortex, which governs thinking. The activation of these three regions explains why human perception of pain is a complex combination of sensation, emotional arousal, and conscious thought. In addition to receiving and interpreting pain signals, the brain responds to pain by activating parts of the nervous system that send additional blood to the injured part of the body or that release natural pain-relieving chemicals, including serotonin, endorphins, etc. Causes of pain. Pain is caused by any stimulus which causes or has the potential to cause tissue damage. Types of pain. Pain can be categorized in several ways. The categorization of pain aids in pain assessment and treatment. Pain can be categorized according to duration, pathology or etiology, which results in the categories of nociceptive and neuropathic pain, classification according to duration. Acute pain. It is usually sudden or caused by a specific event, such as infection, inflammation, surgery or injury. It lasts for hours or days not exceeding 1 month. It may be continuous or recurrent. It often results from tissue damage. It can be associated with headache or muscle cramps. It goes away as the injury heals or the stimulus is removed. Acute pain may cause increased heart rate, increased blood pressure and anxiety. Chronic pain. It persists beyond the usual time for healing to occur, generally more than 3 months. It may exist for months or years, often from progressive diseases such as arthritis, AIDS and cancer. It rarely causes an increase in heart rate, BP, but can cause loss of appetite, sleep disturbance and depression. It is resistant to most treatments. Classification according to pathology. Pain can basically be categorized according to its origin as nociceptive and neuropathic pain. It can also be categorized as being psychogenic. 1. Nociceptive pain. This occurs when pain-sensitive nerve endings called nociceptors are stimulated. It goes away when the injury is healed. Most nociceptors in the human body are located in the skin, joints and muscles, and the walls of the internal organs. Nociceptive pain may be somatic or visceral somatic pain. Originates in the skin or subcutaneous tissue, muscle, bone and ligaments, and is often referred to as musculoskeletal pain. Specific receptors nociceptors for heat, cold, vibration, stretch, inflammation and oxygen deprivation are activated and result in somatic pain. Characteristics of somatic pain: sharp and throbbing. Well localized. Can be reproduced by touching or moving the area or tissue involved. I. Visceral pain. Arises from the visceral organs, like the body cavities, the thorax, abdomen and pelvis. Specific receptors for stretch, inflammation, and oxygen starvation are stimulated, leading to visceral pain. Characteristics of visceral pain: poorly localized. May feel cramping, like a vague, deep ache, sometimes are colicky in nature. Frequently produces referred pain to the back. Pelvic pain refers to the lower back, abd. Pain refers to the mid-back, thoracic pain refers to the upper back. 2. Neuropathic pain. This results from injury to or malfunctioning of the nervous system and can occur in different forms. Sharp, spasm-like pain can occur along the course of one or more nerves such as the trigeminal nerve in the face or sciatic nerve in the lower back or extremities. Severe, burning pain may be associated with injury to a peripheral nerve in the extremities. It may involve the central nervous system, the peripheral nervous system, or both. Neuropathic pain is usually associated with an identifiable disorder such as stroke, diabetes or spinal cord injury, and is frequently described as having a burning quality. Phantom pain is also a neuropathic type of pain, which is the sensation of pain from a limb or organ that has been lost or from which a person no longer receives physical signals. Phantom limb pain is an experience almost universally reported by amputees and quadriplegics. 3. Psychogenic pain. This is pain is the one that is influenced by psychological factors. The patient is genuinely experiencing the pain, but it has either no organic explanation or it has a weak one. Common psychogenic pain syndromes include chronic headache or low back pain, atypical facial pain, or pelvic pain of unknown origin. Some cases of psychogenic pain belong to a group of mental disorders known as somatoform disorders. It is a pain disorder characterized by physical pain that is intensified by psychological factors, often becoming the focus of the patient's life and impairing his or her family relationships and ability to work. Physiological dimension of pain. Physiological processes of pain. Pain involves 4 physiological processes: I. Transduction, I. Transmission, E. Modulation, if. Perception, I. Transduction. This is the conversion of the mechanical, chemical or thermal stimuli into an action potential, and this occurs at the level of the peripheral nerves, nerve endings known as nociceptors. Damage to tissue will cause release of chemicals like prostaglandins, histamine, etc. which activate the nociceptors. This generates an action potential which converts the pain stimulus into an impulse, i.e., transmission. The pain impulses move from the site of transduction to the brain. Transmission involves movement of the pain impulse from the site to the spinal cord, then from the spinal cord to the brain stem and the thalamus, and finally from the thalamus to the cortex for processing. Perception. This is the conscious experience of pain. At this stage, pain is recognized, identified, and the individual experiencing it responds. Modulation sensory adaptation. This is the protective reflex that occurs with pain perception. It is often described as the descending system, and this final process occurs when neurons in the thalamus and brainstem send signals back down to the dorsal horn of the spinal cord and modifies incoming impulses. Dimensions of pain. 1. Physiologic dimension. This is the transmission of nociceptive stimuli. 2. Sensory dimension. This is the recognition of the sensation as being painful and being able to describe it. The elements usually described are the pattern, area, intensity, and nature of pain. 3. Affective dimension. This is the emotional response to the pain experience. The response may be anger, fear, depression, or anxiety. 4. Cognitive dimension. This involves the beliefs, attitude, memories, and meaning one attributes to the pain. 5. Behavioral dimension. This is the observable actions used to express the pain or control it, egg crying. Factors that influence pain. 1. Physiological factors of pain. Age. The age of a person influences how he expresses and perceives pain. Young children have difficulties in describing or expressing pain. Fatigue. The sense of exhaustion intensifies pain and decreases the ability to cope. Clients with long-term illnesses with lack of sleep have a greater pain perception. Genetic makeup. This influences an individual's pain threshold and tolerance. Neurological function. Pain perception can be affected by any interruption to the pain pathways. Clients with neuropathy may experience altered pain sensation. 2. Social factors. Attention. Pain becomes greater if more attention is focused on it. Distracting it decreases the pain. Family and loved ones. Social support. The presence of helps minimize the pain. Previous experience. A client who has had successful pain relief will take necessary measures, whereas a person who has had the same type of pain is aware of what he or she will experience and will have a different perception of pain. 3. Cultural factors. Meaning of pain. The meaning of pain to an individual influences the experience of pain. Ethnicity. Cultural beliefs influence the way one perceives and expresses pain. Some ethnic groups prohibit the expression of pain. 4. Spiritual factors. Pain may be perceived differently depending on an individual's spiritual understanding of the purpose of pain. Some people believe that pain is punishment from God and they will endure it, while others believe that God is loving and he cannot let his children undergo pain. The reaction to pain will be according to their spiritual conviction. 5. Psychological factors. Anxiety often accompanies and increases the intensity of pain. People who believe that they can control the pain have decreased pain perception, while those who feel they cannot control the pain have increased anxiety and perception of pain. Assessment of pain. It is important to assess pain because it guides the management of the pain. Pain is assessed by eliciting the following information. I pattern of pain. Ask the client about the onset and duration of pain. Acute pain increases with activity, egg dressing of a surgical wound, and diminishes with time, while chronic pain waxes over time. Ask the client how and how often the pain recurs. i.e. area of pain location. Assessing the location of pain helps in identifying the possible cause and treatment. Ask the client to describe the pain using anatomical landmarks by mentioning or pointing to the area of pain. Pain may be difficult to localize as it may radiate to some other parts of the body. Egg angina pain which radiates from chest to jaw to left arm. Intensity of pain. Assessing the severity of pain helps to identify measures for treating the pain. This is the most important characteristic in pain management. Pain scales are used to help patient communicate the intensity of pain. The commonly used scales are the Descriptive Pain Intensity Scale, Numeric Pain Intensity Scale and the Visual Analog Scale. IV. Nature of pain. This is the quality and characteristic of pain. Patients may describe pain as follows. Sharp pain. Aching pain felt when muscles are tired. Shooting pain felt when nerve tissue is involved. Burning pain. Gripping pain when intestines are involved. Throbbing pain when there is inflammation with formation of pus. Stabbing pain occurs when serous membrane is involved. Pounding pain. What relieves pain? Ask the client if they have any effective way of relieving their pain. Applying hot or cold compress. This helps in identifying nursing interventions from what the patient is already familiar with. What increases pain? Ask what factors contribute to onset of pain or increase it. This helps in management of pain by avoiding contributing factors. Effects of pain on ADLs. Ask client how the pain has affected his quality of life and well-being. Ask how he is managing and if he is able to take care of himself. Management of pain. Pain management refers to a set of skills and techniques for coping with chronic pain. The goal of pain management is not complete elimination of pain, rather it is to teach the patient to keep the pain at a level that he can tolerate and make the most of life in spite of the pain. Basic principles of pain management. Pain should always be believed as it is subjective. Every patient deserves adequate pain management. Treatment should be multidisciplinary to address all dimensions of pain. Treatment should be based on patient goals which are set at initial assessment. The treatment plan should be a combination of drug and non-drug therapies, although drugs are usually used in moderate to severe pain. Clients and family members should be involved. All therapies must be evaluated to ensure they are meeting the patient's goals. Drug side effects must be prevented and/or managed. Non-pharmacological strategies for pain management. These help reduce the dosage of analgesics required to control pain. They alter ascending nociceptive input. They are in two classes: E. Physiological and cognitive therapies. A. Physical therapies. I. Massage. This involves manipulation of the soft tissues of the body through stroking and rubbing to increase circulation, improve muscle tone, and relax the patient. I. Transcutaneous electrical nerve stimulation. This involves delivery of an electrical current through electrodes applied on the skin surface over the painful region. E. Acupuncture. This is traditional Chinese medicine in which tiny needles are inserted into the body at designated points. The needles stimulate sensory nerves to send impulses to the spinal cord and brain to release endorphins to relieve pain. IV. Acupressure. This combines acupuncture and massage and uses fingertips to apply pressure and stimulate pressure points. V. Heat therapy. This is application of heat to the skin. Superficial heat therapy uses an electrical heating pad, while deep heat therapy uses hot water bottles or immerses the patient in hot water. Heat therapy is used to treat chronic pain. A warm bath can also be used to relieve pain. Cold therapy. This involves application of towels soaked in cold water, ice bags or ice massage to the skin. It works best within the first 24 hours of an injury and acute pain. V. Exercise. Physical exercise stimulates the body to produce endorphins which help reduce pain. X. Naturopathy. Naturopaths include dietary advice and nutritional therapy which is effective for some patients suffering from chronic pain syndromes. X. Hydrotherapy. Warm whirlpool baths ease muscular and joint pain. B. Cognitive therapies. Cognitive therapies act on the patient's mind by changing his perception of pain, alter the pain behavior and provide clients with a greater sense of control over the pain. I. Distraction diversional therapy. This involves redirecting the client's attention to something away from the pain, e.g. music, television, prayer. Music therapy. This involves compassing or listening to music or both. Some research shows that music works by temporarily blocking the gates of pain in the dorsal horn of the spinal cord, while other research shows that music stimulates the release of endorphins which help reduce pain. Music also treats pain by diverting the person's mind away from the pain and creates a relaxation response. Prayer and meditation. Prayer helps many people to relax. Prayer also refocuses an individual's attention and diverts their mind from the pain, i.e., relaxation. This technique relieves anxiety and muscle tension. It includes deep breathing, slow and rhythmic breathing. Yoga. If practiced under a doctor's supervision, yoga helps to maintain flexibility and range of motion in joints and muscles. Guided imagery is structured distraction technique that uses the patient's own imagination to develop a sensory image and pleasant memories. Pharmacological therapies. Analgesics are given according to severity of the pain. Non-steroidal anti-inflammatory drugs, NSAIDs, which include acetylsalicylic acid, ASA, ibuprofen and diclofenac. These are used to manage mild or moderate pain. Paracetamol is also used to manage mild to moderate pain. Non-steroidal anti-inflammatory drugs combined with an opioid are used to manage severe pain. Opioids. Narcotics are strong painkillers derived either from the opium or from synthetic compounds that have similar effects. These include codeine and morphine. These are controlled drugs because they have a high potential for abuse. References: Berman, A. and Snyder, S. 2012. Cozier and Erb's Fundamentals of Nursing. Concepts, Process, and Practice. 9th edition. Pearson. Boston. Lewis, S. M., Heitkamper, M. M., Dirksen, S. R. 2004. Medical Surgical Nursing. Assessment and Management of Clinical Problems. 6th edition. Mosby.St. Louis, Missouri. ISBN 0-323-016103. Monahan, 2007. Phipps Medical Surgical Nursing. Elsevier, Missouri. ISBN 13 978 0-7234-3456-6.